this. So, ma'am, please, I would like you to take over and share your screen and start your lecture, please, ma'am.
Thank you so much. So I'll just start sharing my screen. Can you see my screen?
Yes, ma'am, we can see it.
Right. So at the outset, I would first like to thank the organizers for having me here. And I just want to compliment each of the faculty member for such amazing talks. It was really a pleasure to listen to all these sessions. Now, we are going to discuss today the hepatic lesions in non-cirrhotic liver, and we'll do it as a case-based discussion. So during this next 20-25 minutes, we'll see some of the representative cases showing different type of enhancement pattern, because that is one of a major criteria to differentiate non-cirrhotic liver lesions. Usually the lesion is first detected on ultrasound, after which a contrast enhanced CT or MR is performed. And on these scans, the lesion is categorized based on the enhancement pattern in one of these categories. There may be hyper-enhancing lesion without any washout. Just a minute, I'll just make it laser. So the most important in this hyper-enhancing lesion without washout is hemangioma, which is very commonly seen. The other two very important differentials are FNH and adenoma. Sometimes we see hypervascular metastasis, and uncommonly we see some cases of epithelioid hemangioendothelioma or nodular regenerative hyperplasia. There may be hyper-enhancing lesions with washout. There is some overlap between first and second categories in form of adenoma and hypervascular metastasis. HCC is a very important lesion in this category, apart from primary NET and sarcomas. Then there may be rim-enhancing or hypo-enhancing lesions, especially hypovascular metastasis, cholangiocia, abscess, granuloma, or lymphoma. There may be non-enhancing lesions, or there may be iso-enhancing lesions. So we'll just see some of the representative cases of these categories one by one. Now, first of all, we'll combine the first two categories for our first set of cases because there is some overlap. So this is the first case, a 40-year-old male presenting with complaint of short duration atypical chest pain, and ultrasound abdomen was performed, which revealed multiple hypoechoic liver masses. So with this, a contrast CT was done. On the contrast CT, we can see that liver is non-cirrhotic, and there are numerous masses throughout the liver parenchyma, few are smaller, few are larger, showing homogeneous enhancement on both early and late arterial phase, with almost iso-enhancing on portovenous phase images and still on delayed venous phase images. So with this kind of imaging pattern, a differential diagnosis of hypervascular metastasis versus multiple FNH was considered. And with this, a MR was performed with multi-hands. So on this MR, we can see few more lesions distributed throughout the liver parenchyma. They were in both the lobes. And on post-contrast images, as on CT, we can see the lesions are iso2 hyper-enhancing. In the background, there are few tiny cystic spaces. And these are the delayed hepatobiliary phase images. We can see some contrast in the duct, in which the lesions were again iso2 hyper-enhancing. So there is no washout of contrast from the lesions. These are the plain T1 and T2 weighted images. This is a T2 weighted image. This is one of the lesion, the larger lesion, which can be seen almost iso-intense to the background liver. There is no fat on in and post phase images. And in the background liver, we can see these multiple tiny cystic spaces, which are suggestive of biliary hematomas. So with this, we gave a possibility of FNH-like lesions on a background of biliary hematomas, because we know that biliary hematomas are, although mostly asymptomatic and just incidental finding, but they may cause some background liver fibrosis, as they are a spectrum of fibropolycystic disease of liver. And this was proved on histopath as a case of FNH, as one can see on these slides, with background biliary hematomas. So this is a rare association, not very commonly seen, but we had picked up, especially thanks to the hepatobiliary phase of MR. Now, FNH-like lesions are almost similar to FNH, except that there is some difference in the clinical background, the background liver parenchyma. Otherwise, the enhancement pattern and the malignant potential histopath are almost same. So although A classical sporadic FNH is mostly seen in a young or middle-aged woman. The FNH-like lesions can occur in any person without any gender predilection, with presence of some predisposing factors. These predisposing factors may be some compromise in hepatic outflow or inflow, some chemotherapeutic agents, especially oxaliplatin, radiation, or stem cell transplantation. The number of lesions are usually multiple in FNH-like lesions. MR signals are almost same on plane, except that in FNH-like lesions, sometimes there may be some signals like regenerative nodules, mild T1 hyperintensity and T2 hyperintensity. The background liver is usually abnormal in FNH-like lesions. Malignant potential is absent and histopath is same. So just as a companion case, this is a classical case of a sporadic FNH, which we are much used to see. And we can see that this is a mass in the caudate lobe of liver, almost isointense to the liver parenchyma, except for this mildly hyperintense scar. This is mildly hyperintense on diffusion weighted images. There is marked enhancement even on early arterial phase, which is significantly enhancing on late arterial phase images and becoming iso-enhancing on venous phase images. In the early arterial phase, we can even see these tiny vessels within the center of the lesion along with the scar. So the delayed hepatobiliary phase images, if we are seeing these kind of picture in a liver lesion in a non-cirrhotic parenchyma, then they are almost classical for FNH. They are typically popcorn-like lesions, and there may be some radiating septae. And why this hepatobiliary phase hyperenhancement occurs? Because these lesions have a overexpression of OATP1B1 receptors, which are responsible for uptake of the POPTA component of the contrast. And also there is increase in well-differentiated bile ducts, which leads to stasis of the contrast in these lesions. But this feature is not always exclusive for FNH. A lot of beta-catenin adenoma and some inflammatory adenomas also show hepatobiliary phase hyperintensity. Though beta-catenin adenoma is a relatively small proportion of adenoma in total, but whenever they do happen, they are also they may also mimic FNH on hepatobiliary phase. Even in cirrhotic patients, few well-differentiated HCCs which have functioning hepatocytes may show this hepatobiliary hyperintensity, and some cholangiocarcinoma and metastasis may show this hyperintensity mainly because of their fibrotic stroma or the cystic component. Now, all the FNH do not show that classical homogeneous hyperintensity. Few may show heterogeneous hyperintensity. There may be homogeneous isointensity, or there may be hypointensity in the center with a hyperintense rim. So this feature is also quite classical for a FNH. The reverse pattern can be seen in an intrahepatic cholangiocarcinoma, in which the periphery shows washout, while the center shows retention of contrast because of the fibrotic stroma and the extracellular component of multihance. So that's all about the FNH. Now, whenever we talk about FNH, we also have to talk about its sibling. So this is a middle-aged lady with incidental detection of liver lesions on abdominal ultrasound. And these are the MR images. So on MR, we can see that there is a ill-defined mildly T2 hyperintense mass here, which is showing mild diffusion hyperintensity. And these are the in and opposed phase images. We can see that there is a marked signal drop on opposed phase compared to in phase. So this is a very important feature for characterizing this lesion. On post-contrast images, there is a heterogeneous enhancement on the arterial phase with hypoenhancement on portovenous phases. And this is the delayed hepatobiliary phase in which the lesion is hypoenhancing. So these are classical imaging pictures of hepatocellular adenoma. Now, adenoma has been classified initially in the 4 categories, and then subsequently 2 more categories were added. Inflammatory is the commonest kind of adenoma, which is classically associated with obesity, diabetes, and hepatic steatosis, and there is a high risk for hemorrhage. HNF1 alpha is the second commonest, and it is a good variety of adenoma because it has the lowest risk for hemorrhage and minimal risk for malignant transformation, especially when the tumor is small. And this is characterized by fat on imaging. So when we see a fatty adenoma on imaging, we can say that this is a good variety of adenoma. Beta-catenin is the worst kind of adenoma because it has a higher risk of malignant transformation and also more common in men. The sonic hedgehog, which was later added, has the highest risk of hemorrhage, and this is also associated with obesity and hepatic steatosis, just like inflammatory variant. So adenoma can be differentiated on FNH on the basis of hepatobiliary phase, but on standard portovenous phases, almost 90% of adenoma show washout which belong to the HNF1 alpha or the beta catenin subtype. But the inflammatory subtype, a lot of them show persistent enhancement. And because we know that inflammatory subtype is quite a common subtype, so adenoma may show either persistent enhancement or washout on the standard portovenous phase images. So without doing a hepatobiliary phase, sometimes it is not easy to differentiate adenoma from FNH. Now, adenomatosis is another condition which is not just like multiple adenoma, rather it is a condition which is not associated with steroid medication or any gender predilection. And the adenomas which are present in this condition are inflammatory HNF1 alpha or beta catenin types. So why there is so much fuss about characterizing adenoma from FNH? Because on one hand, FNH is totally innocuous lesion, does not usually cause any problem once properly diagnosed, while adenoma may be associated with bleeding and malignant transformation. So bleeding can be seen in about a quarter of adenomas. And when the patient has obesity or is taking OCPs, or the lesion size is more than 3.5 centimeter, lesion is in left lateral segment, exophytic, or has visible arteries or sonic hedgehog variant, then there is a higher risk of bleeding. The malignant transformation is seen in about 4 to 8% people, and it is more when the lesion is more than 5 centimeter or is beta catenin or mixed subtype. And on imaging, whenever in a adenoma we see growth or vascular invasion, then we should always suspect malignant transformation and subject the patient for resection at least. Now, another entity in this category of hypervascular liver lesions is nodular regenerative hyperplasia, which is a diffuse micronodular transformation of parenchyma due to disturbed microcirculation. Various systemic diseases and drugs are associated with presence of NRH. So whenever we see these kind of lesions which are hyperenhancing on arterial phase, usually not showing any washout, or they may be mild washout also. So we should always take the history of these underlying conditions. A very common condition which predisposes to NRH, as also talked in morning, is Budd-Chiari syndrome. So as we can see in this patient, there is a IVC stent which is in place, and these are multiple NRH developing in the parenchyma. So in this kind of these kind of lesions, we should not apply Liarets. This is a contraindication for applying Liarets. Moving on to the next case, a 52-year-old lady with complaint of abdominal pain and fullness. So although this is not a very common entity, but whenever this does happen, it is the responsibility of radiologists to diagnose this, because there are virtually no other tumor markers or anything else which can help to diagnose without performing a liver biopsy. So in this, you can see that there are large confluent liver lesions and few discrete ones. Lot of lesions are distributed in the subcapsular location. There is associated capsular retraction. You can see that the background parenchyma otherwise does not show any parenchymal nodules, but there are features like cirrhosis, there is ascites, there is splenomegaly. So it is causing pseudocirrhosis of the liver. So pseudocirrhosis is a condition which can be caused by any infiltrative liver lesion, whether malignant or benign. On diffusion weighted images, these lesions are showing diffusion hyperintensity. There is hyperintense signal on ADC map also. And on post-contrast images, there is heterogeneous enhancement more in the periphery, and gradually the lesions are filling up on portovenous phase images. But the main clincher to make the diagnosis is the hepatobiliary phase, in which we can see that the enhancing portion has rather progressed. There is no washout. There are still some patchy non-enhancing areas which have some cystic degeneration. So these are not having contrast enhancement. And besides these confluent lesions, we can see this targetoid appearance or a rim-like stratification in few of the lesions here and also in this location. And so with this kind of morphology, one can think of hepatic metastasis, diffuse hepatocholangiocarcinoma, or hepatic epithelioid hemangioendothelioma. Now, the first two entities should not show washout on hepatobiliary phase images. Apart from that, most of the picture may be confusing. But once you see that the lesions are not showing washout, then this makes it a case of hepatic epithelioid hemangioendothelioma, which is a tumor arising from vascular endothelium. Biologically, it behaves between angiosarcoma and hemangioma. And actually, in this entity also, there are various kind of dedifferentiation. One may see very benign kind of hemangioendothelioma, or there may be some progression towards malignancy. On imaging, there are subcapsular hypervascular coalescent lesions. Target appearance may be seen at few places. There may be maze-like appearance, lollipop sign as seen here, that this is the candy and this is the vein which looks like a stick which is suddenly occluded by the lesion. And there is a persistent enhancement on hepatobiliary phase, which as we saw in the previous slide. The counterpart, the benign counterpart of this entity is the hemangioma, which with which we are all very familiar. The characteristic T2 shine-through effect on diffusion-weighted images, the classical irregular peripheral discontinuous nodular enhancement, and the giant hemangioma, which also shows similar kind of enhancement pattern, but because of the huge size, it develops ischemia in the center with scar, cystic areas. Sometimes there may be some dystrophic calcifications also. And one should remember that both hemangioma and giant hemangioma, they show a pseudo washout, unlike the hepatic epithelioid hemangioendothelioma, because these lesions are not hepatocyte containing, and the the flow of contrast within these lesions is not as slow as hemangioendothelioma, so they show a washout on hepatobiliary phase images. So we have seen the benign counterpart of hemangioendothelioma. Let us see the malignant counterpart. This is the elderly male who presents with abdominal pain and malaise without any fever or jaundice. And these are the CT images in which we can see that there is a very ugly looking necrotic mass in the right lobe of liver. There are few other satellite lesions in the remaining liver parenchyma. On the arterial phase only, we can see visible arteries within the mass, and there are few patchy arteries visible in the remaining necrotic areas also. On the FDG PET images, we can see that there was a high FDG uptake even in the necrotic component of the lesion. So there's a very aggressive kind of tumor. So one can think of hypervascular metastasis, atypical HCC, or mesenchymal tumor in these kind of cases. The patient was also carrying a scan which was done just 2 months back, in which the mass was significantly small in size and the satellite lesions were also not there. So this proved to be a case of hepatic angiosarcoma, which is the most common malignant mesenchymal tumor of liver. More commonly seen in elderly male, there are several carcinogens which may be associated with this entity, like thorotrast, vinyl chloride, arsenic. And on imaging, there is usually early heterogeneous enhancement with progressive filling. So moving on to the next case, a 56-year-old man with chronic diarrhea and weight loss. So in recent time, there has been a lot of increase in these kind of cases. Now just see, the liver parenchyma is non-cirrhotic, and you can see one hypervascular mass in segment 5. There's a tiny calcification along the margin of the mass. It is showing washout type of kinetics. There is rapid arterial phase enhancement with washout. And besides this main lesion, there is another tiny lesion in the left lobe of liver. So when we are seeing these two masses in the non-cirrhotic liver parenchymal background, we always think of hypervascular metastasis besides HCC. So hypervascular metastasis, we know, can come from NET, renal cell, breast, melanoma, and thyroid. So when you look back at the case carefully, you can see that there is this hyper-enhancing lesion in the body of pancreas also. So this is a case of pancreatic NET, which has given rise to metastasis in the liver parenchyma. So with currently now the people are taking a lot of PPIs. So with that, there has been a rapid increase in the incidence of these NETs, which were usually not seen earlier, but now we are commonly seeing these kind of cases. So pancreatic NET with metastasis may sometimes be associated with syndromes like MAN1, VHL, tuberous sclerosis, or NF1. Clinical presentation may be different depending on the type of primary. If it is insulinoma, may present with Whipple's triad, gastrinoma with Zollinger-Ellison syndrome, glucagonoma may present with 4D syndrome, and the non-functioning tumors, because they don't have any specific symptom, so they tend to present late. And the companion case, non-cirrhotic liver, and we can see almost similar kind of case, lesion in the parenchyma with exophatic component. And the hallmark in this particular mass is presence of these cystic or necrotic spaces. So although the solid component is not very large and the mass is not looking very aggressive, it is a very well-defined rounded kind of mass, but there are these cystic or necrotic hypoenhancing areas. So when you see these cystic necrotic hypoenhancing areas, you always should keep a differential diagnosis of NET besides a more common diagnosis of HCC. So with that, the histopath showed NET in this particular case, and the DOTA-PAT showed very high DOTA avidity. So primary liver NET are, although not very common, and you need to document absence of lesions at other sites like small intestine, pancreas, and lung. But on imaging, you can suspect them whenever you see cystic spaces in a hypervascular mass of non-cirrhotic liver. Which PET CT to advise? If they are looking like poorly differentiated lesions, then FDG has a higher avidity. And if they are well differentiated tumors, then DOTA has a higher avidity. A companion case, in this we can see a well-defined mass in the right lobe of liver, hyperintense on T2, hypointense on T1 weighted images. There is one small hemorrhagic area in the anterior part of the mass, which is T1 hyperintense. There is marked diffusion hyperintensity and mildly hypointense signal on ADC map. When you see the post-contrast images, you see this classical mosaic kind of enhancement. So whenever you see these lobulated mosaic kind of enhancement, you should always suspect a possibility of HCC. Also, there is this corona enhancement, and on delayed venous phase images, there is this capsular enhancement also. And these are the hepatobiliary phase images in which there is a washout and capsule is seen. So HCC in non-cirrhotic liver has a bimodal age distribution. It may be seen in second decade or 7th decade onwards. And usually they are larger than cirrhotic liver HCC because the patient is not having routine screening and they usually present late. But still, despite the larger size, they have a better overall survival because the underlying cirrhosis is not there. So the patient has a better morbidity and mortality after a surgical treatment of these patients. Another companion case, a 55-year-old lady with abdominal pain and fullness. On MR images, these are the T2 and diffusion weighted images and in and post phase images. You can see there is a large lobulated mass rising in the left lobe. There is marked diffusion hyperintensity. There is another tiny satellite lesion. You can see some IHPR prominence here. On in and post phase, there is a background liver parenchymal stenosis. The mass as such does not have any significant fat. You can see this demarcation of sort of corona around the lesion. On post-contrast MR images, you can see that there are prominent vessels in the periphery of the tumor. There is marked enhancement on the early phases, and enhancement is more in the periphery. There is a central hypoenhancing area. And these are the delayed hepatobiliary phase images in which you can see there is a peripheral washout and contrast has migrated towards the center of the lesion, except for a small hypoenhancing central area. And this is the satellite lesion, which is also showing hypoenhancement. So when you see this kind of picture, you should always suspect a possibility of biphenotypic hepatocolangiocarcinoma. In this, there are features, few features favoring cholangiocarcinoma and few features favoring HCC. So features favoring cholangiocarcinoma may be a peripheral rim enhancement in the arterial phase, presence of duct dilatation, some satellite lesions, and features favoring HCC are heterogeneous enhancement in the arterial phase, washout, and also the intralesional arteries. Because of the dual pathology, the prognosis is usually worse than either of the entity, and there is a very high risk of recurrence, especially with male sex, macrovascular invasion, and lymph node metastasis. And whenever you see a corona type of picture, like in this case, it always indicates a microvascular invasion at least. So we have completed the discussion of hypervascular liver lesions, which may or may not show washout. Now, switching gears, moving on to rim enhancing or hypoenhancing liver lesions in a non-cirrhotic parenchymal background. The important differentials are metastasis, cholangiocarcinoma, abscess, granulomas, and lymphoma. So let us see this case. A 59-year-old lady with abdominal pain, and these are the plain MR images. So whenever you get these kind of even non-contrast MR images, this is pretty diagnostic of the entity. You can see that there is a very well-defined lobulated mass in the subcapsular part of liver. Considering the size of mass, there is a marked capsular retraction. The mass is very bright on diffusion, dark on ADC. There is no fat. On post-contrast, there is a rim-like enhancement, heterogeneous in the periphery. And then on delayed hepatobiliary phase images, there is a peripheral washout and central hyperenhancement. So this is a typical case of a intrahepatic cholangiocarcinoma. It shows rim enhancement, as we saw, progressive and delayed central enhancement. IHBR dilatation distal to the tumor can be seen when the tumor is centrally located. And when it is peripherally located, like in this case, there is a capsular direction. So another case of a centrally located cholangiocarcinoma, which is again showing a heterogeneous rim kind of enhancement in the early phases, which is then persistent. And in this, there was associated tumor extending in the adjacent bile duct. Another case of a centrally located cholangiocarcinoma with upstream biliary dilatation, which shows features of hemophilia. Sclerosing hemangioma is another entity which very closely simulates cholangiocarcinoma, but I think one should not give a prospective diagnosis of sclerosing hemangioma because it is much more rare than cholangiocarcinoma, and there is almost no way to differentiate except for high CA19-9 levels, and ADC value sometimes may be higher in sclerosing hemangioma, but still it is a very risky situation to call it as sclerosing hemangioma rather than a cholangiocarcinoma. Hepatic abscess are not difficult to diagnose. There is a rim-like enhancement, but there is a clinical syndrome associated with it. The patient has pyrexia, abdominal pain. There may be associated parenchymal edema. So moving on to the next category of non-enhancing lesions. So this is a very interesting case, and unless you know this entity, it will be difficult to diagnose. This is a young male coming from Central Asia presenting with abdominal pain, decreased appetite, weight loss, and jaundice. On post-contrast MR images, you can see this large non-enhancing lesion involving almost entire left lobe, and the margins are a bit shaggy, irregular, infiltrative looking. On T1 and T2 weighted images, you can see a few tiny cystic areas at the margin, and there is no significant diffusion restriction in this particular case. And there are feathery calcifications on CT scan. So this is a classical case of alveolar echinococosis. In this, there is an infiltrative multivascular mass which progresses at the periphery and regresses in the center. This is classically seen in the northern hemisphere, somehow not seen in the southern hemisphere. And this is a counterpart of the classic cystic echinococosis or Echinococcus granulosus, with which we are all very familiar. And this cystic echinococosis, whenever we see on imaging, there are various signs associated which are well known to everyone. We should try to classify them in one of these categories because these help in making the management protocol easier. Next case, a 45-year-old lady presenting with short history of severe upper abdominal pain with epigastric fullness. And you can see this large cystic non-enhancing lesion almost involving the entire left lobe with exophytic component. The exophytic component is protruding in the subhepatic area. And there is associated IHBR dilatation, and you can see some membrane-like thing in the IHBRs here and here. So you can think of MCN, hydatid, liver abscess, simple cyst, or intrahepatic resolving hematoma in these kind of lesions. So there are few points which are in favor or against hydatid. The point in favor is presence of IHBR dilatation in intraductal membranes, while the points against may be that the lesion as such does not have daughter cyst or any other telltale evidence of hydatid cyst. So with the first two differentials, the patient was taken in OT and was resected. And this came out to be MCN. There is an ovarian kind of a stroma. And the content which was projecting into the biliary system was actually a prolapse of MCN rather than exactly a rupture. So these tumors classically, as opposed to the popular belief that they communicate with biliary system, they do not communicate, but they may prolapse into the biliary system. This is another classical case of MCN spotter kind of case. And whenever you see areas of enhancing soft tissue, papillary projections, hypervascularity, or thick calcifications in these kind of lesions, then you should always suspect malignancy. The last case, isoenhancing without washout, are classically fatty lesions, and the sequence to go for in these kind of cases is the in-phase or post-phase MR image, which leaves no doubt about the type of lesion. Otherwise, it is confusing on CT and other MR sequences. So that's it. The differential diagnosis can be narrowed down based on the enhancement pattern. It is very important to look at the clinical inputs, the history, LFTs, And besides the enhancement pattern, the other imaging markers like T1, T2 signal, scar, and fat. And above all, the most important thing is to have a problem-solving attitude rather than referring to correlate clinically. One should try to get all the information and try to solve it yourself. Thank you.
Thank you so much, ma'am, for the insightful lecture. Now, next, I would like to invite Dr. Sudhir